This is in summary, a new diagnosis of stage 4 lung adenocarcinoma in a patient who is PD-L1 negative. And there are a couple of trials that have read out over the past now few months that are relevant in terms of how we should think about the management, because that has shifted. And the first is Keynote 189, and the second is Checkmate 227. So we'll talk a little bit about that data. The first trial, Keynote 189, was a follow-up to Keynote 21G, which was a subarm of a phase 2 trial, taking a look at carboplatin pemetrexed with or without pembrolizumab in the first-line setting. Keynote 189 was a randomized phase 3 trial now of dealer's choice platinums, cisplatin carboplatin, with pemetrexed, with or without pembrolizumab. And pemetrexed in this setting could be continued as a maintenance therapy with pembrolizumab as an option for the clinician and the patient. And at the end of the day, the trial was positive. It was positive in the intention to treat analysis in terms of overall survival. The subgroup analysis showed that there was benefit pretty much in every single subgroup in terms of PFS, overall survival, and overall response rate. And I think this was what was most powerful, is that in each of the PD-L1 cut points that we care about that are clinically relevant, this would be the high expressors, PD-L1 greater than 50%, in the intermediate category, PD-L1 1 to 49%, and in the negative category, PD-L1 0%, we had a significant overall survival advantage. So patients were living longer. And the hazard ratios were pretty much comparable. They were all around a hazard ratio of 0.5 for overall survival. This was also carried over to PFS benefit in each of the subgroups, as well as overall response rate benefit. So all three clinical metrics were better. And the toxicity was not that bad. There was not very much of a signal in terms of any increased toxicity outside of what you would expect when you give patients pembrolizumab, which was a relatively low rate of autoimmune adverse events, which we are sort of used to. But this was not increased over what we'd expect from single-agent pembrolizumab. The next trial that had read out was Checkmate 227, and this was both at AACR as well as ASCO. And Checkmate 227 was a randomized phase 3 trial, again in the frontline setting for non-small cell lung cancer patients, taking a look at a variety of different nivolumab-based regimens. This was ipilimumab-nivolumab versus chemotherapy nivolumab versus standard chemotherapy in non-small cell lung cancer patients. The trial was originally designed to take a look at stratification by PD-L1. But based on some interim analyses where tumor mutation burden seemed to be a predictive biomarker, the trial was amended to take a look at TMB as a potential biomarker stratified by a high and low status, with the cutoff being 10 mutations per megabase. And that is what was carried forward in the presentations. And the trial was also positive. I think the best slide that showed this was essentially in the entire population with TMB stratified by PD-L1 status, where the benefit in terms of progression-free survival was found irrespective of PD-L1 expression. This was in the low as well as the high category. And it's important to note also, in terms of the data that was presented, that ipilimumab and nivolumab did seem to be, particularly in the PD-L1 negative population, the best regimen. This was followed by chemotherapy plus nivolumab, and then finally by chemotherapy in terms of the PFS benefit. I think overall, what we were left with was now a real predictive biomarker for a nivolumab-based regimen. Where it's a little bit difficult now to figure out what the niche is, in part because overall survival data has not yet been presented for the Checkmate 227 regimen. And I think that hampers our ability to compare this regimen to other first-line regimens that have come up. And this will be, I think, a lot of the discussion that we have in this specific case.